intrinsic defects leading to an increased erythrocyte destruction. The red blood cell structure and its role in the intrinsic defects. So the plasma membrane is key to maintaining the characteristic biconcave shape of the red blood cell. Proper red blood cell deformability is essential to navigate through narrow capillaries in the splenic sinusoids, which is critical for red blood cell longevity. The structural features that support deformability include the biconcave or discoid geometry of the cell, the elasticity of the membrane, and the cytoplasmic viscosity, largely determined by the hemoglobin concentration of the cell. For the membrane protein complexes, so the membrane integrity is going to depend on the transmembrane protein complexes, and these proteins include ankyrin and actin. These provide vertical structural support by anchoring the lipid bilayer to the underlying cytoskeleton. Defects or mutations in these proteins can cause instability of the membrane, which can lead to membrane loss or shape abnormalities and increased red blood cell destruction. For cytoplasmic viscosity, so this is dependent on the concentration of the hemoglobin inside the red blood cell. The increased viscosity can reduce deformability, contributing to the premature red blood cell destruction. For pathophysiological impacts, so the intrinsic membrane defects can reduce the red blood cell lifespan by decreasing deformability, causing hemolytic anemia, such as, if they have hereditary spherocytosis, and elliptocytosis are also things that can cause this. Most defects in the red blood cell membrane that can cause hemolytic anemia are hereditary. However, acquired defects also exist. So hereditary red blood cell membrane defects have historically been classified by morphological features, and that is this list of them here. For hereditary spherocytosis, so by definition, it is a hemolytic anemia that's caused by defects in the proteins that disrupt the vertical interactions between red blood cell transmembrane proteins and the underlying cytoskeleton. This leads to membrane instability and loss of membrane surface area. The incidence, it occurs in approximately 1 in 2,000 to 3,000 individuals of Northern European ancestry. For pathophysiology, so the primary defect is a loss of red blood cell membrane, which results in a reduced membrane surface area. This causes the red blood cells to become spherocytes, which are small, dense, and less deformable. These abnormal red blood cells are prone to sequestration and destruction in the spleen or extravascular hemolysis. For clinical features, we have anemia, which are due to the increased red blood cell destruction. They can show jaundice as well from the increased bilirubin that's produced during the red blood cell hemolysis, and splenomegaly, which is the enlargement of the spleen from the increased red blood cell clearance. Some laboratory features for hereditary spherocytosis. So we will see the presence of spherocytes. These are small, dense, round red blood cells. So as you can see on the picture over there, they kind of look like little balls next to regular red blood cells. They lack a central pallor, and they are indicative of membrane loss and decreased surface area. For a CBC and indices for hereditary spherocytosis, they will see an anemia of varying severity. They will have an increased mean corpuscular hemoglobin concentration, or an MCHC, and this is due to decreased cell size and relatively increased hemoglobin concentration. Reticulocytosis will be there as well, and it will reflect the compensatory marrow response. For bone marrow, this is typically going to show erythroid hyperplasia, which will indicate an increased red blood cell production in response to the hemolysis. So hemolytic indicators, so they will have elevated indirect or unconjugated bilirubin. They will have increased lactate dehydrogenase, or LDH. They'll have a decreased haptoglobin. For the osmotic fragility test, these red blood cells will demonstrate increased fragility in hypotonic solutions due to reduced membrane surface area. For the eosin 5 malamide, or EMA binding test, this uses a fluorescent dye that binds to band 3 and other membrane proteins. And patients with hereditary spherocytosis will show a decreased EMA binding, which can help aid in the diagnosis. Some complications for hereditary spherocytosis. So most patients have compensated hemolytic anemia and are rarely symptomatic. They may experience some symptoms during crises, and this could include like a hemolytic crisis. This is often triggered by viral infections. They could have an aplastic crisis. This is something that comes on sudden and severe, and they have a severe drop in hemoglobin and reticulocyte count. And this is usually due to the parvovirus B19 infection. They can have a megaloblastic crisis as well, and this is in moderate to severe cases. Patients may develop folic acid deficiency due to the increased erythropoiesis. For treatment, often no treatment is necessary for these compensated cases, but if they are not compensated, they may need a blood transfusion, and this may help during the hemolytic and aplastic crisis phases. For the diagnosis, we must be able to distinguish this from an immune hemolytic anemia, which involves the antibody-mediated red blood cell destruction. Hereditary elliptocytosis. So by definition, this is caused by defects in proteins that disrupt horizontal or lateral interactions within the red blood cell cytoskeleton. This affects the stability and flexibility of the membrane, which leads to the elliptical shaped red blood cells. So if you look at the picture down there, they kind of look like long hot dogs, maybe, compared to a regular red blood cell. So that is what an elliptocyte looks like. For incidence, this occurs in approximately 1 in 2,000 to 1 in 4,000 individuals in the United States. There is a higher prevalence in Africa and Mediterranean regions, and this is possibly due to the selective advantage against malaria. For clinical features, the majority of patients are actually asymptomatic, but around 10% will experience moderate to severe anemia. For the laboratory features in the blood smear, we're going to see those elliptocytes, so those elliptical or cigar-shaped red blood cells. These abnormal shapes result from the membrane cytoskeleton defects. For treatment, usually there is no treatment required for the asymptomatic cases, but if they are symptomatic in the severe cases, they could need a splenectomy or a blood transfusion could be considered as well. Hereditary pyropoikilocytosis. So definition, this is a severe form of the hereditary elliptocytosis. This is characterized by extreme red blood cell instability. Some clinical features, they have a notable heat sensitivity of red blood cells, which leads to increased hemolysis at elevated temperatures. Patients will often present with severe hemolytic anemia. As far as laboratory findings go, we will see marked poikilocytosis on peripheral blood smears with highly variable and fragmented red blood cell shapes. The red blood cells show increased fragmentation and abnormal morphology compared to the typical hereditary elliptocytosis. Hereditary ovalocytosis. The alternative name for this is Southeast Asian ovalocytosis. So by definition, this is a condition that is caused by a mutation in the band 3 gene. This leads to increased rigidity of the red blood cell membrane. It provides a resistance to malaria parasite invasion. So the prevalence of this is it's pretty common in Southeast Asia with a prevalence up to 30% of some populations. In the laboratory, we're going to see in the peripheral blood smear, we're going to see those oval-shaped or ovalocyte red blood cells. And just like you think, they are oval in shape instead of the typical round like a red blood cell. We're also going to see a presence of the 1 to 2 bars or ridges across the red blood cell membrane. So if you look at the picture, normally the red blood cell has that circle, that lighter circle in the middle. These ones actually have like a line, 1 or 2 bars across them. For overhydrated hereditary stomatocytosis, so by definition, this is a very rare hemolytic anemia, and it is caused by a defect in red blood cell membrane cation permeability. This leads to overhydration of the red blood cells. So the pathophysiology of this is we have some ion movement, so the abnormal influx of sodium into red blood cells and loss of potassium can disrupt the ion balance. For water movement, water will follow sodium into the cells, and this can cause red blood cells to swell and become overhydrated. For clinical features, these patients are going to present with moderate to severe hemolytic anemia, and in the lab, we're going to see 5 to 50% stomatocytes that are going to be seen on that peripheral blood smear. These are red blood cells that have kind of like a slit appearance in the middle instead of that round central pallor. So if you look at the picture down there, they kind of have more of like a slit looking, center instead of that round. We're going to also see a presence of macrocytes with elevated mean corpuscular volume, or the MCV, will range from 110 to 150 femtoliters. Reticulocytosis will indicate bone marrow compensation and will have an increased osmotic fragility due to the decreased surface area to volume ratio. So swollen cells are more prone to rupture. For dehydrated hereditary stomatocytosis, another name for this is hereditary xerocytosis. So by definition, this is an autosomal dominant hemolytic anemia that is caused by a defect in red blood cell membrane cation permeability. This results in dehydration of red blood cells. It is the most common form of stomatocytosis. For laboratory features, we will see a mild to moderate anemia. We'll also see reticulocytosis, which will reflect the bone marrow's response. For clinical signs, the patient may present with jaundice and splenomegaly. And back to the lab, we may see a decreased mean corpuscular volume, or an MCV, and that is due to the cell dehydration. We will see an increased mean corpuscular hemoglobin concentration, or an MCHC, and we will also see a decreased osmotic fragility, unlike in the overhydrated stomatocytosis. Some other hereditary membrane defects with stomatocytes that we'll briefly go over is familial pseudohyperkalemia. This is characterized by excessive potassium leakage from red blood cells in vitro at room temperature. Potassium leakage does not occur in vivo at body temperature. Cryohydrocytosis, this causes mild to moderate hemolytic anemia with stomatocytosis present. This results from cold-induced leakage of sodium and potassium from the red blood cells. Rh deficiency syndrome, this is caused by an absent or decreased expression of Rh membrane proteins. Some hereditary membrane defects with acanthocytes. So we have neuroacanthocytosis. This is characterized by neurological impairment in presence of acanthocytes or spur cells on the peripheral blood. Then we have A-beta lipoproteinemia. This is a lipid metabolism disorder causing acanthocytosis and neurological symptoms. Then we have McLeod syndrome, which is an X-linked disorder with acanthocytes and neuromuscular symptoms. Then we have chorea acanthocytosis, which is a neurodegenerative disorder presenting with acanthocytes in choreiform movements. So acquired red blood cell membrane abnormalities so the first one we're going to talk about is acquired stomatocytosis. This is often a result of drying artifacts on the blood smears. This is seen in about 3 to 5% of healthy individuals without any clinical significance. The next one is spur cell anemia. This is caused by excess free cholesterol and severe liver disease. This is due to abnormal plasma lipoproteins. Free cholesterol accumulates preferentially in the outer leaflet of the red blood cell membrane. The spleen will then remodel the red blood cell membrane into acanthocytes or spur cells with long, rigid projections. These abnormally shaped red blood cells become trapped and destroyed in the spleen, which can cause a rapidly progressive anemia of moderate severity, splenomegaly, and jaundice. The prognosis, so this is pretty poor in end-of-life or end-of-stage liver disease, but anemia may improve if the patient undergoes liver transplantation. Paroxysmal nocturnal hemoglobinuria, so the etiology of this is it is caused by the acquired clonal mutation in the hematopoietic stem cells. It leads to circulating blood cells lacking GPI-anchored proteins on their surface, particularly the CD55 and the CD59. The absence of CD55 and CD59 makes the red blood cells vulnerable to spontaneous complement-mediated lysis. The incidence, this occurs in approximately 2 to 5 cases per million people. For pathophysiology of this, so there is different subpopulations of red blood cells that exist based on the expression of the CD55 and CD59. So the first one is the PNH-1 or I. So this is normal red blood cells with a normal CD55, CD59 expression. PNH2, which is the partial deficiency of CD55 and CD59. And then we have PNH3, which is the complete deficiency of CD55 and CD59, which actually results in spontaneous hemolysis by complement. For paroxysmal nocturnal hemoglobinuria, so in clinical findings, the onset will usually present in the patients when they're about 30 to 40 years old, but it could occur at any age. Symptoms may include fatigue, pallor, and signs related to anemia. Common complications are going to include jaundice and thrombosis or blood clots. In the laboratory, we're going to see a degree of anemia, which could range from mild to severe. We're also going to have positive hemoglobinuria and hemoglobinemia, which is the presence of free hemoglobin in urine and plasma due to the intravascular hemolysis. Patients are also going to appear jaundiced, so this is from the increased bilirubin due to the increase in red blood cell destruction. And then thrombosis, this is actually a significant risk in paroxysmal nocturnal hemoglobin. in patients, and this is often in unusual sites. So not your typical, calf and things like that. Some special diagnostic tests we can do for paroxysmal nocturnal hemoglobinuria. First one is the sugar water test, and this detects the increased red blood cell fragility in the hypotonic solution, which can lead to hemolysis in the paroxysmal nocturnal hemoglobinuria cells. We also have the HAM test, which is an acidified serum test. This test for complement-mediated lysis of red blood cells in acidified serum. This will be positive in paroxysmal nocturnal hemoglobinuria. For classification, we have classic PNH, and this is the clinical hemolysis with symptoms. For hypoplastic PNH is associated with bone marrow failure syndromes like aplastic anemia, and subclinical PNH, which is minimal symptoms, which are basically often an incidental finding. So this will be talked more on the next slide. For treatment, we can do eculizumab, and this is a humanized monoclonal antibody which is targeting the complement protein C5. It actually blocks the cleavage of C5 into C5a and C5b, which prevents the formation of the membrane attack complex. This reduces complement-mediated red blood cell destruction and hemolysis in paroxysmal nocturnal hemoglobinuria patients. So red blood cell enzymopathies. So we have the glucose 6-phosphate dehydrogenase deficiency, or the G6PD. So the role of G6PD is it protects hemoglobin and other cellular proteins and lipids from oxidative denaturization. It maintains redox balance in the red blood cells by generating NADPH, which helps regenerate or reduce glutathione. For genetics, the G6PD gene is located on the X chromosome, making the deficiency X-linked. This will mostly affect males, but females can be carriers or affected if the homozygous or with skewed X inactivation. For prevalence, the G6PD deficiency is the most common red blood cell enzyme defect worldwide, and it affects approximately 5% of the global population. There are multiple variants that exist with differing enzyme activity levels and clinical severity. So the pathophysiology of G6PD deficiency, so the mechanism of Heinz bodies formations. So the oxidative stress will cause a denaturization and precipitation of hemoglobin, which actually forms Heinz bodies inside the red blood cell. These Heinz bodies attach to the red blood cell membrane, marking the cells for destruction, which would then lead to a hemolytic process. So the red blood cells with Heinz bodies are removed by the splenic macrophages, which lead to extravascular hemolysis. In severe oxidative stress, intravascular hemolysis can also occur. Some associated clinical syndromes, so we have drug-induced hemolysis. This is caused by certain drugs like antimalarials or sulfonamides. These can trigger oxidative damage, which can also cause hemolysis. There can also be infection-induced hemolysis, and this is infections, can increase oxidative stress and provoke hemolytic episodes. Fava bean-induced hemolysis. This is the consumption of fava beans, which actually can trigger an oxidative damage, which can lead to hemolysis in certain individuals. Neonatal jaundice, so newborns with G6PD deficiency are prone to jaundice due to an increased hemolysis. Chronic non-spherocytic hemolytic anemia, so some variants can cause a chronic hemolysis even without oxidative triggers. Protective against Plasmodium falciparum, so the G6PD deficiency provides some resistance to malaria, particularly the P. falciparum, and that explains its high prevalence in endemic areas. For laboratory findings on the peripheral blood smear, we're going to see again that presence of Heinz bodies, and they can be visible with special staining. We're also going to see bite cells, which are red blood cells with bites removed by the splenic macrophages. We are also going to see reticulocytosis during the hemolytic episodes. For the complete blood count, we're going to see anemia. It's often normocytic or slightly macrocytic during hemolysis, and we can also have an elevated reticulocyte count, which would indicate the marrow response. For the G6PD enzyme activity assay, so this is a definitive test that shows the reduced G6PD enzyme activity. It may be falsely normal, though, during acute hemolysis due to reticulocytosis, because reticulocytes have a higher G6PD activity. Some other labs that we would see would be an elevated indirect or unconjugated bilirubin due to hemolysis. We would also see an increased lactate dehydrogenase, or an LDH. We would also see a decreased haptoglobin. For treatment, we're going to discontinue the drugs that are triggering it, so try to avoid those known oxidative drugs and agents. And then we'd also do some patient care, so blood transfusions if they're having some severe anemia, and if it's from an infection, we're going to try to treat those promptly. For patient education, we're going to counsel patients to avoid fava beans and oxidative drugs. Pyruvate kinase deficiency. So pyruvate kinase is an enzyme, and it is a rate-limiting enzyme in the glycolytic pathway of the red blood cells. It catalyzes the conversion of phosphoenol pyruvate to pyruvate, generating ATP, which is essential for the red blood cell energy and survival. It is an autosomal recessive disorder, and it is found in about 1 in 20,000 in the white population, and it is found worldwide. For significance, it's the most common form of hereditary non-spherocytic hemolytic anemia. For clinical manifestations, the spectrum can range anywhere from severe anemia all the way to asymptomatic, where the patients, they don't even know they have it. Some common findings include anemia, jaundice, splenomegaly, an increased incidence of gallstones, and this is due to chronic hemolysis. For laboratory features, we'll see variable hemoglobin levels. We'll also see reticulocytosis, which reflects the bone marrow compensation. On the blood smear, we're going to see anisocytosis, which is variation in size. We're going to see poikilocytosis, which is variation in shape of red blood cells. We're going to see polychromasia as well, which shows that there are immature red blood cells present. And then we're going to see Burr cells, also known as echinocytes. White blood cells and platelets usually are going to be normal or maybe even slightly increased. We're also going to see an increased indirect or unconjugated bilirubin and lactate dehydrogenase, LDH, due to hemolysis. For treatment, it's mainly just going to be a supportive therapy, but we could do blood transfusions if needed if they are having a severe anemia.